In general, the complications are those of neurological and non-neurological. Say if you has septicemic meningococci and meningitis, then you can end up with neuropsychiatric or neuropsychological or neurocognitive. These are different things, but it all relates to the neuro. Okay, the commonest complications may be, especially in adults and children, and adults, non-neonates, is the hearing loss. So sensory, it's neurosensory hearing loss, and this is very important in children because if you don't hear, you don't learn speech, you don't speak well, and your learning abilities will be diminished, and you become somebody else. So, in summary, this disease has a very severe complications, and it has to be treated as so. Okay, where do we find tuberculosis in the world? Okay, tuberculosis all over the world, including Africa, Middle East, and America and other countries where there is development. Okay, why this spread? Okay, we have one side which is epidemic. We can have epidemic of meningococci or epidemic of meningitis, and this is in an area sub-Saharan Africa, which Sudan is included. North of it is the north of the line is Tunisia and Algeria, and the south of it is Uganda, Kenya, Rwanda, and Tanzania. And this is will give you the area of the epidemic. Okay, why is this so? The epidemic is not every year. It can come for every 4 years or for every 5 years. But when it comes, it really hits bad because we can have patients, 4 out of 1,000 of patients will have meningitis. So with that, I think we need some powerful prophylactic and some powerful prevention. Why is it in that area? There are many theories. Meningococci is a normal inhabitant of the nasopharyngeal, and so is Streptococcus pneumoniae. These are inhabitants. They are colonizing our throat and nose, but they get virulent. Sometimes they get capsulated, and once they are capsulated, they become virulent and leaving a very bad effect on the body. So they become virulent and they go in, penetrate into the bacterial part. Okay. It is thought that the cause of this epidemic is because of dryness, because these areas are dry and they are dusty storms, which will decrease the immunity of the mucosa and allows penetration into the mucosa. Okay. The important part, again, is that we have to treat, during the epidemic, we have to treat patients as well as carriers, because secondary infection, which is basically contracted from a patient, can be prevented by prophylactic antibiotics. Okay, we can talk about 3 categories of patients. 3 categories. The first category is neonate. Okay, neonate, and then from that period, second week to 2 years. That is another period, and then children and adolescent. And the third part is elderly. The elderly behaves like the children, okay? As far as the symptoms are not very mature, the symptoms are not very mature, and the symptoms are subtle, okay? The classical symptoms of meningitis is one, fever. Number two is tender nuchal pain and rigidity or neck pain, okay, and stiffness. And the third is diminution of consciousness or some impairment of consciousness. This is the classical. And you can add to it in children, you may have convulsions, you may have photophobia, like you cannot tolerate light, and then the fever becomes severe, and convulsions can occur. Okay, neonates is a special category. The neonates are a special category, and particularly premature neonates. Why? Why that? Okay, now with the development of ICUs, neonatal ICUs, okay, intensive care units, then we do have a lot of premature babies who come out to be mature. Okay, so there is keeping life of prematurity, and this is why we now can recall one of the causes of mortality of premature is infection. So this is now, we have data to tell us what is the prevalence of infection in neonates and premature. Why is a premature baby a different baby? Number one, prematurity is not only prematurity of the systems like GI and respiratory, but also it is a premature in terms of immunity. Okay, both cellular and humoral immunity. A premature baby would have the IgG will be less than 20, IgM will be less than 20, and IgG will be less than 5% from the adult level. Okay, IgA only starts after birth. So the immunity here is diminished. And whenever you have immunity, you are susceptible to infections. Whenever you have immunity depression, you have susceptibility to infection. Okay. What are the organisms here? Because this will lead us to how to prevent it. The commonest is Streptococcus beta streptococci, which is called Streptococci agalactiae, which is Streptococcus B, and we will come to it, but others is E. coli and Listeria monocytogenes. So this is the some of the bacteria, and if Arwa is there, if you can see the some of the slides.
Prof.
Yes, slides. We have some slides here. Just to put these bacteria into the memory. Okay. Bacterial meningitis. Meningitis is bacterial, either viral or fungal, as we said. And then you have neonatal meningitis and post-neonatal meningitis. Okay, and then the causative organism is, again, slide. The causative organism is in adults, as we said, is meningococci and pneumococci be the highest, and this will at least constitute 85% of the general cases of meningococci. So this is neonatal, and in neonate we don't expect symptoms, classical symptoms, obviously. When the baby will become off color, poor feeding, and then respiratory distress. And these are very common symptoms of neonates, and unless you are experienced, you may miss a serious bacteria, septicemia and meningitis. So you have to have a high index of suspicion And usually, any cause of bacteremia or septicemia or sepsis in a unit is the fatality is very high, maybe up to 90%. Okay, uh, where is the source of this infection, streptococci? It's usually in the birth canal, and these children will get it during delivery. So, uh, rectovaginal infection with Streptococcus B, is the source. And to the extent that we need to uh, examine ladies at 35 weeks of pregnancy, swabs from the perineum, the mother perineum, the vagina, and the rectum. And if the culture is positive, pregnant ladies will be given chemoprophylaxis, because this have been shown to reduce the incidence of streptococcal infection in childhood or in units. This is one. Chlorhexidine can be used during delivery to clean the perineum and early the entrance of the vagina and area of the rectum, area of the anal area, and this will also reduce the infection. When we go from second week to 3 months, the bacteria which can cause meningitis may be different. This will include Staphylococci and Klebsiella. I think it's important to remember these bacteria. Why? Because now we have vaccine against meningococci type A and C. We have vaccine against pneumococci, and we have vaccine against Haemophilus influenzae. These vaccines have really improved the health and decreased the incidence and prevalence of meningitis in neonates. So it is something which we could hammer on to get away what are the bacteria. Luckily, most of these bacteria are responsive to the penicillin group, which is benzyl penicillin, ampicillin or ampicillin, and the cephalosporins, which are ceftriaxone or cefotaxime. Okay, the infection with streptococci is very common in the whole world, but unfortunately, it is 3 times worse in Africa. You remember, we are talking about now medicine in Africa. So it's important that we should remember that the general environment of all these is bacteria prevalence. True, the bacteria is now getting resistance in the States and Europe because of the generous use of antibiotic. Still, we have low resistance to antibiotics in Africa because the lack of use of antibiotics early. But anyway, it's an environment which is full of bacteria. Are there any special conditions where we should look for infection even before occurring? Yes, we talked about premature, and the premature is proportional to gestational age. Okay, if you have a near-term baby, then the chances are less to get neonatal infection. That's number one. So prematurity with gestational age. Number two, early rupture of the amniotic fluid or rupture of the membranes. This is again predisposes the mother. All right, and then obviously if there is infection around the perineum. And in the neonate, just to repeat, is that the symptoms are subtle, okay, and they are general, sort of irritability, poor feeding, and respiratory distress. So don't depend on the symptoms and signs of meningitis. And these are you may not find it in a neonate. What are these signs? One is bulging fontanelle. Is bulging fontanelle here. The bulge indicates increased pressure inside. Opisthotosis, curving of opisthotonos is a curving of the back, opisthotonos, and it is spelled O-P-I-S-T-H-O, opisthotonos, T-O-N-O-S, opisthotonos. Okay, this is second indication of meningitis. And then you have obviously the neck stiffness and convulsions. These only occur in about 20% of cases and even less. Okay, so if you go by these signs to diagnose meningitis, then you lose quite a lot. Okay, CSF examination in neonates and in any case of suspected of meningitis is important. It's very important. And as we said, this is definitive diagnosis. You cannot say for sure, swear on the case that this is meningitis unless you have a CSF. CSF is done, by experts, not experts, but good registrars. And you have to make sure that it is a clear CSF, not traumatic CSF, because if it is traumatic CSF, then you can have blood and everything will be, the measurement will be disturbed all over the place. Okay, there are certain contraindications for CSF. Okay, CSF examination or lumbar puncture. Number one is increase in intracardiac pressure. If there is increase in intracardiac pressure, don't do lumbar puncture because this will cause coning of the lower brain into the foramen magnum, and this will cause death. Okay, so avoid, or not only it is contraindicated, and you can tell if there is increased intracardiac pressure clinically or by CT. Clinically by examining the fundus, and if there is papilledema, then this is a high pressure, high internal or cerebral edema. The second is if there is bleeding or if there is coagulopathy. If there is coagulopathy, don't do lumbar puncture. Okay, so these are the two. And if there is infection at the back, because you don't want to push a needle in CSF and drive bacteria into CSF. So these are the three contraindications. If you are in doubt about increasing intracardiac pressure, send the child to a CT. And then in the CT, it can be easily told that if there is increase in intracardiac pressure. So avoid. It is not permitted to do lumbar puncture in patients with increasing intracardiac pressure. Okay, what do we expect to find in the CSF? The CSF will be, the pressure will be high. It becomes turbid. Okay, it becomes turbid. It have high protein. It has high leukocytes, which may go up to thousands, okay? And it has low glucose. Repeat, low glucose, high proteins, and abundance of neutrophils or cells. If you take a CSF examination by gram stain, you can see the bacteria, and all CSF fluids should be cultured for the appropriate antibiotic. Okay, having said that, it's important to start. By that time, all patients should have had treatment. And treatment as soon as the diagnosis was suspected. Okay, so what are the prognosis? The prognosis usually, generally neonatal, depends on the urge of starting treatment, okay? But it usually, unfortunately, it was from 50 to 90% of cases. And those who will come out may have some complications, as we said earlier, deafness, may have hydrocephalus and subdural effusion, okay? And these will lead to speech difficulties, language learning, neuromotor disability, and some behavioral problems. Okay. So it's a very serious infection, and it should be followed easily. Okay, what is the septicemic pneumococci? Septicemic pneumococci. This is a general bacteremia. It's a general bacteremia which causes, more than just the meningitis, because these uh, streptococcal pneumonia or meningococci, they get encapsulated. Okay, they get encapsulated, and these capsules are very immunogenic, and they secrete antigens, certain antigens which stimulate inflammatory indicators of inflammatory substances. These capsules contain teichoic, teichoic acid, and lipopolysaccharide, which is an endotoxin, lipopolysaccharide, and peptidoglycan. This stimulates more inflammatory mediators like necrosis factor, tumor necrosis factor, platelet activation, and interleukins. And these will lead to further inflammation. These inflammatory stimulants will lead to inflammation, activation of the neutrophils, activation of the complement, and then they lead to thrombosis, and they lead to vasculitis, and they lead to cerebral edema. So it is just beyond the meningococcal meningitis. And you can find, thrombosis, cold legs, and you can even find some gangrene, or people can have gangrene, okay, because of the thrombosis, okay, and vasculitis, which can lead to necrotic skin. I would like to bring you back to the petechiae, which can occur with neonatal septicemia or meningococcal septicemia. These are early on blanching, but usually it's non-blanching. You cannot, if you press it, they don't disappear. So this is petechiae, and it can precede the infection, okay, because of the problem with this coagulopathy or platelets. So this petechiae has been taken as a sign of meningococcal septicemia, and mothers have been warned against the appearance of this one. And in England at one time, this was in the news, in the lay news, like Guardian, Independent Times. And the story goes that in a bus, in a public bus, a lady saw a child, carried by his mother, and she saw that because they are fair colored, the Caucasians are fair colored, she saw the spot, which she thought just it's a bleeding, or it's an ecchymosis. And then she warned her mother, and then they ran to the casualty or emergency, and the child did have meningitis. So the early diagnosis is very important. Okay, in children you may have some convulsions, but look for predisposing factors. You can have meningitis as secondary to an infection in the ears or in the sinuses. Okay, and the worst scenario with meningococcal septicemia is hemorrhage in the adrenal cortex, hemorrhage of the adrenal cortex, what we call Waterhouse-Friderichsen syndrome, Waterhouse-Friderichsen syndrome, which end up with total loss of adrenal function, hypotension, collapse, and because you lose cortisol, you lose adrenocorticoids, aldosterone, and these are needed for maintaining the pressure. So they get collapse, and the patient is, at a very difficult setting and death. Okay, what is the time now? Yes. Okay. So the diagnosis depends on the clinical white count, CSF examination, and the rest has been dealt with. Okay. The treatment is usual antibiotics, and antibiotics should be given in ample antibiotics. And obviously, in children, you have to calculate according to the weight. And they generally include benzyl penicillin, which is crystalline, what's called crystalline penicillin, and ceftriaxone or cefotaxime, okay? Ampicillin can be added, especially early in the armamentarium of a neonatal, okay? And vancomycin occasionally. Vancomycin occasionally should be added in when, especially in third world, where there are other gram-negative bacilli. So it is an armamentarium, and it needs careful calculation and good follow-up of the meningitis. So I think this is a short lecture, but I would like to summarize that meningitis is an emergency, and in adults, the presentation may not be very acute. It can be insidious, okay? And it can simulate flu, all right? This in adults, all right? It can present flu, irritability, fever, definitely, headache, and neck pain, all right? In children, as we said, or in pediatrics and neonate, the neck stiffness is not that remarkable, or it's absent. But in adults, it is usually present with the neck pain and neck stiffness. This can be, on examination, very easy. If you just put up the neck up, then there is, the meninges the muscles will contract because of the pain. So they would prevent you from flexing. Okay, this can also be done in a sign called Brzezinski sign, which is a patient lying back, okay, flex the hip, and then passively extend the knee, passively on flexion of the hip, like 90%, and then you will be there, flex it passively, and you cannot do this because of the limitation of the irritation of the nerves. This is a sign which can also occur in disc lesion, Brzezinski sign. Okay, so that is what are the precautions for those who are around? Okay, in epidemics, we go ahead with prophylaxis. We go ahead with prophylaxis, giving antibiotics. We used to use sulfonamides, but these are now out of fashion. We use ampicillin as prophylaxis, and this will definitely reduce the rate of infection in the contacts. Okay. Other meningitis, we already dealt with tuberculous meningitis, which is more insidious, okay, more insidious or gradual, and it is the diagnosis is usually taken time because of the symptoms may be vague, symptoms, but later it appears, and the complications with tuberculous meningitis is as severe as with bacterial meningitis. Okay, with that, I would like to close this lecture and see you on Sunday morning, next Sunday morning, when we deal with another disease medicine in the tropics. Thank you very much indeed for being with us.